Welcome to NICU Essentials lecture series. In today's lecture, we will be discussing neonatal hyperbilirubinemia, a common condition in the NICU, newborn nursery, as well as in the outpatient general pediatrics practice. We will be reviewing the pathophysiology of jaundice, differences between physiologic versus pathologic jaundice, risk factors, evaluation, and management. A complex pathway is involved in bilirubin metabolism. Heme oxygenase degrades heme, which is broken down into biliverdin plus carbon monoxide. Biliverdin reductase reduces biliverdin to unconjugated bilirubin. Unconjugated bilirubin then binds to albumin and is transported to the liver. UGT1A1, an enzyme in the liver, conjugates unconjugated bilirubin to conjugated bilirubin. Conjugated bilirubin is then excreted into the intestine via bile ducts. Some of the conjugated bilirubin is excreted in the stool, while some is deconjugated by the bacteria and then reabsorbed into the blood. The following diagram illustrates the bilirubin metabolism pathway in the body. Physiologic jaundice is characterized by an unconjugated hyperbilirubinemia. It can occur starting at 24 hours of life up to 1 week of life. Total serum bilirubin usually peaks from days 3 through 5, and peak levels are usually between 5.5 and 10. Physiologic jaundice often occurs in otherwise healthy infants due to many reasons. Infants have higher rates of bilirubin production due to elevated hematocrits and shorter lifespan of red blood cells. Infants also have an immature hepatic HGT1A1 enzyme activity. Enzyme activity increases dramatically in the first few weeks after birth. Lastly, infants have an impaired ability to extract bilirubin from the body. Breastfeeding jaundice is essentially an exaggeration of physiologic jaundice. It occurs in the first few days after birth. Caloric deprivation combined with mild dehydration leads to an increase in enterohepatic recirculation of bilirubin. Treatment involves successful breastfeeding, which involves 8 to 12 breastfeeds a day with good infant latch and adequate maternal milk production. Additional temporary formula supplementation should be considered if the infant has significant weight loss, poor urine output, poor feeding, delayed stooling, or delayed maternal milk production. In contrast, breast milk jaundice occurs after the first week of life, often during days 6 through 14. Breast milk jaundice is also an unconjugated hyperbilirubinemia. The pathophysiology is unclear, but it is thought that the beta-glucuronidases in human milk inhibit UGT1A1 activity and bilirubin conjugation. Treatment involves discontinuing breastfeeding for 48 hours and initiating formula feeding. The serum bilirubin in breast milk jaundice usually peaks between 12 to 20 and should decrease by 3 milligrams per deciliter per day. If this decrease occurs, then breastfeeding can be restarted. It is important to note that breast milk jaundice may persist for up to 1 to 3 months, so formula feeding may be needed for a longer period of time. Unconjugated bilirubinemia in premature infants involves the same mechanism as physiologic jaundice as described previously. However, kernicterus can occur at lower total serum bilirubin concentrations in premature infants, as low as 10 to 14 milligrams per deciliter. In addition, hyperbilirubinemia in premature infants often lasts longer due to the immaturity of red blood cells, hepatic cells, and the GI tract. Delays in enteral nutrition also lead to an increase in enterohepatic circulation. Pathologic jaundice can be broken down into increased bilirubin production, impaired conjugation, deficiency of hepatic uptake, and decreased excretion, or increased enterohepatic circulation. In hemolytic disease, increased bilirubin production occurs due to increased red blood cell destruction or turnover. Hemolytic diseases include ABO or Rh incompatibility, enzyme defects such as G6PD deficiency, structural defects such as spherocytosis, birth trauma such as cephalohematoma, or polycythemia. Decreased excretion of bilirubin is often caused by biliary obstruction, such as biliary atresia or a choledochal cyst. Decreased excretion can also result from impairment in the excretion, such as Dubin-Johnson syndrome or Rodor syndrome. Crigler-Najjar syndrome causes an impairment in bilirubin conjugation. A severe deficiency in the UGT1A1 enzyme leads to bilirubin encephalopathy and kernicterus within the first few days to the first month of life. In contrast, Gilbert syndrome leads to a transient impairment in bilirubin conjugation, often during periods of sickness or stress. In Gilbert syndrome, UGT1A1 activity is decreased, leading to a benign unconjugated hyperbilirubinemia. Conjugated hyperbilirubinemia is defined by a conjugated bilirubin greater than 1 milligram per deciliter when the total serum bilirubin is 5 milligrams per deciliter, or when the value is greater than 20% of the total serum bilirubin concentration. Causes of a conjugated hyperbilirubinemia include sepsis, cholestasis or biliary atresia, metabolic disorders, and hypothyroidism. Any underlying hemolytic disease or disorder of conjugation or excretion in the infant will be a risk factor for hyperbilirubinemia. More common risk factors for hyperbilirubinemia include Asian ethnicity, prematurity, infant of a diabetic mother, sepsis, and isolated breastfeeding. In addition, certain drugs can lead to a displacement in bilirubin from albumin, causing a rise in total serum bilirubin levels. The following chart summarizes the differences discussed in physiologic versus pathologic jaundice. It is important to determine these differences early, as pathologic jaundice often needs immediate attention and treatment. Kernicterus occurs when unconjugated bilirubin is unbound to albumin, or if there is any damage to the blood-brain barrier, such as in asphyxia, acidosis, or sepsis. Acute bilirubin encephalopathy should be considered if the total serum bilirubin concentration is greater than 25. Symptoms of acute encephalopathy include poor suck, high-pitched cry, hypotonia, and seizures. Kernicterus describes the chronic sequelae of bilirubin toxicity. It often occurs during the first year of life and consists of hypotonia, delayed motor skills, or chorioathetoic cerebral palsy. Evaluation for hyperbilirubinemia begins in the prenatal and immediate postpartum period by assessing for ABO incompatibility. If there is a concern for hemolytic disease, the newborn may be evaluated with a Coombs test, blood type, CBC, and reticulocyte count. Postnatally, the infant should be evaluated every 8 to 12 hours by a visual assessment. If jaundice appears in the first 24 hours, the patient should be evaluated immediately for causes of pathologic jaundice. Otherwise, a transcutaneous or serum bilirubin should be performed between 12 to 24 hours of life or before hospital discharge to assess risk. After plotting the value on the normogram, reassessment can then be determined based on the zone in which the bilirubin falls. The Bhutani Normogram, shown here, allows you to plot the patient's bilirubin against the patient's age to determine the patient's overall risk of hyperbilirubinemia. The Bhutani Normogram is valid only for infants born greater than 35 weeks. This is because preterm infants are at higher risk of bilirubin toxicity at lower total serum bilirubin concentrations. The normogram determines risk zone based on the following risk factors: jaundice in the first 24 hours, ABO incompatibility, gestational age 35 to 36 weeks, prior sibling with phototherapy, cephalohematoma, exclusive breastfeeding, and East Asian race. Management of physiologic or breastfeeding jaundice involves optimizing breastfeeding with lactation consultants and using formula supplementation if needed. If, after discharge, the infant is noted to have risk factors and an elevated bilirubin but not at phototherapy threshold, then the newborn should be followed as an outpatient with repeat serum bilirubin levels and assessment of weight, stool patterns, voiding patterns, and adequacy of oral intake. If the newborn meets phototherapy criteria based on the Bhutani normogram, then the infant should receive phototherapy in the hospital. Lastly, exchange transfusion may be needed in severe cases of hyperbilirubinemia or in cases of hemolytic disease. The following Bhutani curve describes the approximate bilirubin levels at which phototherapy should be initiated based on the neurotoxicity risk factors of the infant. Neurotoxicity risk factors include isoimmune hemolytic disease, G6PD deficiency, lethargy, temperature instability, sepsis, acidosis, or low albumin. Phototherapy works by converting bilirubin into a water-soluble compound called lumirubin, which is excreted into the urine and bile without requiring conjugation in the liver. During phototherapy, the infant should be monitored for feeding, temperature, and hydration status. IV fluids and/or formula supplementation should be considered if there is a concern for dehydration or significant weight loss. A decrease of 0.5 can be expected in the first 4 to 8 hours after initiation of phototherapy. Phototherapy can be discontinued once the total serum bilirubin decreases by 4 to 5 milligrams per deciliter, or if the total serum bilirubin decreases to 13 to 14 milligrams per deciliter. A rebound bilirubin is not routinely recommended. It is important to note that the dose is affected by the distance that the infant is from the light and the surface area that is exposed. Ideally, the light source should be within 10 centimeters of the infant, and the infant should be exposed as much as possible, removing only for breastfeedings. Exchange transfusion is considered a medical emergency and should be considered if the bilirubin is increasing despite phototherapy, which would suggest ongoing hemolysis, rapidly rising bilirubin, signs of hemolytic disease, or signs of acute bilirubin encephalopathy. The following Bhutani curve describes the bilirubin levels that would need to be achieved for the infant based on his or her age to need exchange transfusion therapy. Exchange transfusion involves removing bilirubin and circulating antibodies from the blood and replacing it with the same quantity of donor RBCs via central catheters. The process is continued until the infant's blood volume is replaced twice. An infusion of albumin 1 to 4 hours prior to the procedure has been shown to increase the amount of bilirubin removed. IVIG may be recommended if the total serum bilirubin is within 2 to 3 milligrams per deciliter of the exchange transfusion level. Complications from exchange transfusion include infection, portal venous thrombosis, thrombocytopenia, necrotizing enterocolitis, or graft versus host disease. BiliTool is a useful website that utilizes the Bhutani Normograms and phototherapy guidelines to determine when to follow up bilirubin levels and when phototherapy is warranted. And this concludes our lecture on neonatal hyperbilirubinemia.